What's up, everybody? Welcome to the Med Easy Show. I am your host, Dr. Mo. I know the rhyme, but anyways, welcome to the channel. Today's video is going to be about head injury, and we're going to cover this section in 4 bits. The first bit, we're going to talk about the statistics. The second bit, we're going to talk about why it's an emergency. The third bit, we are going to talk about what we are supposed to do. And the last bit, what you're not supposed to do. It's that simple. Anyways, hit that like button, subscribe, comment, and share this video. I'm not doing it for myself, I'm doing it for you too, and for everybody who is involved and is curious and interested in this field. Anyways, let's get into the video. Number 1, the statistics. Traumatic brain injuries are regarded as a silent pandemic. That's not just a quote, a random quote. It has a meaning. You look at the figures, the global figures, you have about 10 million people suffering from death and disability related to traumatic brain injury, and those are huge numbers. You come and narrow it down, you have 1 in 10 people dying every day due to traumatic brain injury. Those are huge figures, man. Those are really huge figures. And if you look at the risk factors behind it, that is definitely the recreational drug use, and being a man does predispose you to getting traumatic brain injury more than a lady, because every 2 men to 1 woman, that's a significant ratio. Now, I don't know if it is related to testosterone or if we are exposed to a little bit of more, or how do I call it? Is it testosterone or being a man? But anyways, it's all tied together, and I think there's much we can do, especially when it comes to the recreational drug use and operating heavy machinery concurrently. Yeah, if we narrow it down a little bit, head injury or traumatic brain injury is regarded as an emergency. We need to understand something known as the Monroe-Kelly doctrine. And I'm going to try and simplify this for you. Yeah. We'll start by stating it out. It says the contents of the brain are always at a constant. It's that simple. I mean, the contents of the cranium are always at a constant. That means the brain, the vascular supply, the CSF should always be at the same level. Like there's a the equilibrium between the 3 should always be in balance. Should there be a change in the equilibrium, then there is some degree of compensation that is allowed. But if there is more than that can be compensated for, then the impact will be a scourge, a huge problem for the individual, which might even lead to disability and an uneventful mortality. All right, so I will try and explain this using this. Weird, right? But it still makes sense. Now, assuming this is your head, again, weird, but it still helps. Assuming this is your head and the contents, which are the gas and the fluid, these 2 are in balance. Should we alter and shake it a little bit, then see that? It gets a little bit fuzzy. It's trying to reaccommodate and get the balance back in. Should we shake it more, the pressures build up. Should we open, it will help us decompress. I was waiting for this. Yeah, there it is. See? Now, same kind of concept applies to the brain. Should you try and change one of those factors, be it the CSF? Should you increase it? In the cases of hydrocephaly, then you have an increased intracranial pressure. Should you traumatize the brain? In the concept now that we are supposed to be focusing on, which is head injury, then we'll still have an increased intracranial pressure because you have injured the brain and the brain is swelling and the blood is not being taken to other areas because the vessels are kind of constricted. So you have hypoxia where the brain is facing. So you have depression of the respiratory centers and the cardiorespiratory centers. It's a vicious cycle. It keeps on going on and on and on and on and repeating itself. So that's it. So we'll look at the mechanism, and the mechanism I'll describe, I'll leave a reference to it where I've got it. We look at how the brain looks. The brain is a soft structure and it's fairly mobile. Should you hit it, there's some degree of mobility. And if you look at the lower surface of the brain, not the lower surface of the lower surface of the brain is soft. Adjacent to it or underlying it is the irregular contours of the cranium, where you have the anterior, mid, and posterior forces. Those are irregular. Should it scratch against there, then you risk tearing the duras that are overlying there, and the meninges, and you end up having bleeding or lacerations or cuts on the brain, which has an effect on itself. Progressively, if these cuts or the bleeding continues to enlarge, then you're increasing the intracranial pressure and might lead to coronization of the brain, forcing the brain to have another escape route, which means it will be going through the foramen magnum and the supratentorial notch, which keeps in mind, tells you of something known as the Cano-Hans effect or the Cano-Hans notch, something that you will see in epidural hematomas. And we will try and describe this a little bit more in detail in another video of secondary brain injury, which we will focus on next week. But this week, we'll just have a highlight. We have the primary brain injury, we just have the lacerations, the contusions, some of the superficial cuts on the face or the head, or scalp traumas, cephalohematomas more commonly. Those are some of the things that you see in a primary brain injury. Move on to secondary brain injury, you come in now to focus on the hematomas, which you have three, the intracranial, you have the epidural and the subdural, you have the intracerebral, you have the subarachnoid, you have the intraventricular. And looking down to another complication, another section is the hydrocephaly, which also results, and we will delve into this a little bit further in next week's video, because trying to explain this is a little bit it takes a lot of time, and I really want you to appreciate it. We are now focusing on the third part, or when I said the third bit, we're there now. What are we going to do? Divide this into two. One, the Good Samaritan's approach and a clinician's approach. For the Good Samaritan, what are you supposed to do? Number one, try and remove whatever hazardous things are surrounding the patient, be it a fire, be it a spillage of water. Try and keep your patient warm by offering them some clothing and all that. Limit the movement of this patient because you risk furthering more injury and damage to this patient. The best thing and the first thing you should always do, call for help. All right. So we move to the second section, which is what the clinician's approach should be, and this involves the primary survey and the secondary survey. For the primary survey, it involves the first things: A, B, C, D, E. A, involving the airway, maintaining that this patient's airway is okay, and there's some of the things you can do to check if the airway is there is by looking at the chest, if the expansion and the patency of the nostrils, and putting a glass to see if there's mists forming. If I was to tilt my glass down there, then you'd see some mist. A similar concept. The breathing is still again trying to see if the breathing is regular, if the chest expansion is normal, are there any engorged neck veins that are happening? Is this patient going into a pneumo, a hemo, or a tension pneumothorax? All of these things are things you're supposed to watch out for. And when it comes to circulation, this is for a bleeding patient. It's good to make sure that you cap or offer some hemostasis if it is a hemorrhagic process. You try and supplement by giving either fluids, giving 2 IV cannulations, and running like a 2 liter start of saline. Then if it's the other kinds of shock that can set in due to circulatory failure, is it cardiogenic, is it neurogenic? The thing that you should always fear out for in the case of head injury is neurogenic shock. This is because of spinal injury that usually happens concurrently, and the thing that tells you are hypotension, bradycardia, loss of reflexes, paresis, either hemi or paraparesis. Those are the things you should watch out for, and you try and offer stability for that. And that's why spinal injury is something you should always be on the lookout for when it comes to traumatic brain injury. We move on to the D part, and this is known as disability. E is for environment. This D can also be used to stand for drugs, where you talk about the the, what are they called, the emergency drugs. If this patient is going into cardiac arrest and all that, you try and give CPR. If CPR fails, you have all these agents that are used, adrenaline and all that. We now move to the secondary survey, and the secondary survey involves your history. And your history is whereby, again, you'll have a clear outlook of how things were, what mechanism was involved. Was it an RTA? Was it an assault? Um, yeah, and then the secondary survey, again, give a thorough, full physical examination from head to toe. You you balance it up with your investigations, and you have a diagnosis for this patient, and that will be your main area of work. To proceed further, we're going to look at how you're going to control this increased intracranial pressures. Wow, okay. Number one, there are several steps that you're supposed to follow. Number one is like elevating the head of the bed, offering oxygen by ventilation or nasal mask and all that, because patients who have traumatic brain injuries, progressive brain edema, the brain is exposed to hypoxia. So you're trying to supplement and eliminate this hypoxia. You have you can go in for your mannitol. It's usually a gram per kg, given I think TDS, and it will help reduce or resolve the brain edema. The mannitol is a, what is it? It's an osmodiuretic, yes. And then you can supplement with your, because of there is always a Cushing's triad that follows up, that is hypertension, bradycardia, and regular breathing. You have to supplement with, it's, you can use nimodipine. It's a calcium channel blocker. It will try and reduce the blood pressures. The other thing you should watch out for, the other ways of solving your ICP is not just mannitol. You can use hyperventilation. You can use a hypertonic saline to try and reduce your intracranial pressures. Again, it's necessary to not just offer solutions for these intracranial pressures, but remember your patient is in a semi-comatose or in a comatose state. You also have to work on other things, which are bowel care, bladder care, and nutritional support. Okay, we move on to be able to go further into the management of increased intracranial pressures. Then we'll have to delve in a little bit further and look at the complications of the secondary brain injury and what each sections of these parts of secondary brain injury should be managed as per, and that will be highlighted in next week's video as I last bit of the video, which is the fourth bit. And here we're going to focus on what not to do. And number one, do not move this patient unnecessarily. Number two, never, ever, ever, you heard me, ever remove a penetrating instrument or artifact in this patient's body. Either one, you risk more bleeding. Remember, these penetrating objects do offer some kind of hemostasis, so you dislodge that and then boom, blood everywhere. All right, so what are the clinicians' things you should always look out for? Number one is by the books they say dextrose 50% does worsen edema. There's a controversial, and I'll try and link studies to the videos so that you can at least have your take. The impact of steroids in managing head injury. In the case of chronic causes of increased intracranial pressure, such as tumors, then steroids are effective because the cause of increased intracranial pressures in tumors is vasogenic in nature, and it does alleviate that vasogenicity of, if I'm to say so, of that. The other thing that every clinician should be aware of is sedating a patient who just had brain injury. Of course, they might have convulsions. Of course, they might have some irritability and things which would want you to sedate a patient. But the mode of sedating a patient in such a state, if you give benzodiazepines, you're risking so much. Benzodiazepines have been shown to cause or disrupt neuronal regeneration and inhibiting neuronal regeneration. So if you give it, you'll be sending your patient tipping him over the scale, something which you do not want to do. I think we've come to the last bit of the video. I hope you enjoyed. I'm going to share some links in the description of the studies that I've come across, the materials that I've gone through in a sense of reference. And I hope you like this video. Subscribe and share this content. Oh, by the way, I always forget this. Hit that bell thing there, like ding, the one that produces that sound. Yeah, that one. I want you to hit it. Thank you. Bye.